have a roundtable on operational innovations in community-wide screening. For the session, I'd like to call upon the moderator, Dr. Shamim Mannan, and then the panelists, Professor Guy Marks from the Union, Mr. R.K. Kannan from the Mission Director, Telangana, Dr. Sonali Sarkar from Report Consortium, Dr. Vineet Bhatia, WHO SEARO Office, Dr. Amar Shah. I'll hand it over to the moderator.
Oh no, Dr.
Thank you. Thank you, everyone, and very good morning. We don't have one of the panel members here, Mr. Kannan. He couldn't be here because of some competing priorities. But notwithstanding, we have a very good panel. And also, in continuation of what we had been talking yesterday, primarily Dr. Swami yesterday was talking about subclinical TB. What possible could be the way in which you can find out subclinical TB. Dr. Kang was mentioning about innovations and the newer innovations in diagnosing TB, moving away from the labs, which was pretty interesting and very much contextual to what we would be discussing today. And then lastly was Dr. Urvashi saying DDG TB talking about the 100 days active case finding campaign, which is happening in India and would be concluding before the World TB Day. And in context of all of these, also, just in your opening remarks, Guy, you were mentioning about why there's a need to do active case finding. I'll start with you, Guy, in terms of why active case finding now?
Thank you. Well, first of all, thank you for introducing me, and thank you for inviting me. It's very, as I said yesterday, it's very exciting to be here in India at this challenging time in the world. It's also exciting to be here at this meeting and to see the tremendous dynamism and enthusiasm and activity around TB elimination, and particularly around finding new technologies and how to use those new technologies effectively to achieve our goals. And I also said yesterday, and I'll reiterate now, that we are running out of excuses for why we can't do this. We actually, have been able to do it in some countries, even with old tools, even with tools that we had available, in the 60s and 70s and 80s. But now we have much better tools, and we have diagnostic tools that can diagnose a patient. Most patients with infectious pulmonary TB, the great majority of patients with infectious pulmonary TB, within a couple of hours of collecting a sputum specimen. We can not only diagnose them, but we can identify those that have rifampicin resistance TB, and therefore we can decide, and we can now combine that with the fact that we have not only highly effective treatment for treating drug-susceptible TB, but we also have highly effective and available treatment for treating patients with drug-resistant TB, with rifampicin-resistant TB, and also even with resistance to many other drugs, many other first-line drugs, and so we can. And so we put all that together, we can diagnose TB, we can identify who needs which treatment regimen, and we can deliver an effective treatment regimen that has a very high chance of delivering a cure to virtually everybody with TB. And I challenge you to tell me what other diseases we have that advantage for. We certainly don't. We can't cure people with HIV, for example. We can't cure most people with cancer. There are very few diseases that we can readily diagnose and readily treat everybody with the disease, and we can with TB. So in that position, we can't say we need something new. We're waiting for a vaccine. We're waiting for a better test. We're waiting for a better drug. We could probably say that 10 years ago, but we can't say it in 2025. We can't say that. It's not to say that there cannot be improvements. And a lot of the discussion here has been about how we can improve particularly the diagnostic technology, but there can also be improvements in the tolerability, particularly of our treatment regimens. But we have drugs that can achieve diagnostics and drugs that can achieve our goal. What I would argue is that we're not using them. We're using them in a way which was more suited to the knowledge and the technology that was available 30 or 40 years ago than it is to the knowledge and technology that is available today. And that is where our major deficit is. We need to change the way in which we use the tools that we have to actually effectively um, deal with this thing. And one of the major findings, now coming to answer your question, one of the major findings, which is we've sort of known about really since the late 2000s, since there were studies done in 2007, prevalence survey in Vietnam, for example, the National Prevalence Survey, which showed then that about half of all prevalent cases of TB in Vietnam had no denied symptoms. And many other studies since then have replicated that, both in Africa and in Asia, and including in India. We know that about half of the patients who have pulmonary microbiologically confirmed pulmonary TB and are then therefore very likely to be infectious to others are not diagnosed on the basis of symptoms. So symptoms become largely irrelevant to finding the source cases of infection. And we need, if we can't rely on symptoms, then that has two important implications. One is that without symptoms, nobody is going to seek care. Nobody seeks care when they're feeling well. You only seek care if you have a cough or you're breathless or you're coughing up blood. So we cannot, for that 50% of patients who are infectious to others but don't seek care, we can't rely on a pathway that is based on patients seeking care for their problem. And the second is, if we do screen the population, there is no, if we only screen for people who have symptoms, we're immediately reducing our sensitivity to 50%. And it'll be less than 50% because whatever test we apply will have a less than 100% sensitivity. So we're immediately, we cannot use symptoms as an entry point to testing for TB in a screening algorithm. The third point to make, and it seems, is that in countries with a very high burden of tuberculosis, the disease is quite widespread. The view that the disease only exists in selected groups of the population was a view basically imported from the HIV world, where that is true. In HIV, there are clearly defined risk groups, and the disease only really exists in that group. It's unusual outside that group, except in very high burden settings like South Africa. But in most of the rest of the world, it isn't. But that is not the case for an airborne transmissible disease like tuberculosis, where it's not based on injecting drugs. It's not based on men who have sex with men. It's based on being in proximity of somebody else who has TB. And we are, if you're in India, we're all in proximity to somebody else who has TB. So therefore, we're all at risk. So if you put all of those things together, there is it seems fairly intuitive to me, and we've demonstrated the the validity of that intuition in our study in Vietnam, and others are starting to demonstrate it as well, that you need to do community-wide active case finding using a symptom agnostic test. And if you do that, you have a profound and rapid impact, not only on the prevalence of the disease, but on the, very importantly, on the incidence of the disease. So that's why I've been advocating for this model. So I might stop there. Probably spoke long enough.
Thanks, Sai.
Yeah.
So, also the other thing is, since you're talking about going into the community and doing screening, you gave an example of what the findings have been from the prevalence surveys. Now, clearly, which is pretty intuitive when we look at the prevalence surveys anywhere in the globe where they have conducted, and the amount of the number of TB patients what we diagnose out of asymptomatics. But then in practical setting, when we get into the community and when you really want to start talking about TB or plan active case finding, uh, many other things come into play. So Professor Sonali, it's for you. In terms, you have done a lot of work on social capital, but specifically what I'd want to know from you is when it comes to active case finding or going into the community and want to do TB screening, stigma, don't you feel that stigma would be a concern? Thank you.
Thank you, Shamim, for that question. And I'm actually glad to be here in this panel today among this august audience and this panel. So, as you rightly said, stigma is a problem. And we had done some studies in Pondicherry and nearby districts of Tamil Nadu and observed the stigma is not only perceived but enacted stigma, and stigma not only from the community, the family members, as well as the health sector. The healthcare workers, the health professionals also are not, because these people are also part of the community they come from, and the stigma inherent, the deep rooted stigma is also expressed in their behaviors. So when a patient goes to a health center, the patient at first is looked upon, no, with not well, and you are supposed to cover your face and stay away, don't come close. So this enacted stigma is there everywhere within the family. Women are not able to disclose their diagnosis in the family because of the fear of being thrown out of their houses. So but what happens, this stigma actually reduces the social capital. I mean, I think I was about to.
Should I put what you had?
Yeah, you can. So we did a small exploratory study to see, to compare the social capital of TB, newly diagnosed TB patients, as compared to their household contacts, and also TB patients who had completed treatment a year before we did the study. And what we found, that the social capital in all the domains of this social capital was actually lower in the newly diagnosed TB patients. Trust, solidarity, the groups and the networks, everywhere the social capital in all these domains was higher. When it was the poorer quartile of the social domain, we had higher proportion of the TB patients. And thank you. So but then when the patients got cured after a year, when they are coming back to a near normal life, the levels are improving. So this poor social capital among the TB patients is because of the stigma. But I have we also observed that when you do a case finding is necessary, as Dr. Guy was telling, that there is no excuse to not do the case finding and let the TB infection cases out there in the community infecting others. They are not having symptoms, they are not coming on their own. So active case finding and the finding of subclinical TB cases is imminent. We can't give any more excuses. But what, there are two approaches. Either we were doing all these years like household contact screening or the social contact screening. But when we were doing the household contact and social contact screening, the experience we faced in the community is, when you go to a targeted group, you have to disclose the reason why you have gone there. So if I'm going to a household contact where the TB patient has not actually disclosed his or her diagnosis to the family members, what do I say? Why I've come there? Why I'm screening them and not their neighbors, not their friends? And it's even more difficult when we go to the social contacts, because I'm not supposed to disclose the identity of the case, but I'm going there to screen them. And then the question is asked, why are you screening me? Why not the other people in the community? So the targeted screening was actually tough to do. But with the community wide screening, it is a wholesome approach. I mean, everybody is being screened, and there is no risk of being disclosing the identity of the cases. And in the Pondicherry experience, we had this just recently concluded the 100-day TB campaign that we were talking about. We had some good experience. So the screening, community wide screening, was being done by the health system. And in a country or in a place where the health system is functioning well, the people have that trust and the confidence on the health system, because these are the health workers who come to my house to provide maternity care, child care, and every for NCDs, for every health problem I go and seek, I receive services. So there's a trust and solidarity between the health system and the community. So when this screening program is coming from the health system, it is much more accepted, better accepted. And before that, we also had a lot of propaganda advertisements in TV, in radios, saying this, the screening going on for tuberculosis, please come forward, get yourself screened, get treated. And we also had school based IC campaigns in all the government schools in Pondicherry, so where the children also know. And we have also seen the children, when they go back to their families, they tell their parents, you have cough, please go to the health center and get screened. So this all helped. And patient and the house to house visit by the all the healthcare workers. So community wide screening was was in a campaign mode, and the acceptance was good among the people. So stigma was relatively less when nobody is being identified as a person having TB. And it's just general screening where everybody has to undergo. And this was the data from the Pondicherry state TB office. After 50 days of the 100 days campaign, we had about 41 positives. So these are the numbers that underwent the X-ray and gave their sputum. So when everybody is doing this, so I am also not unhappy being part of the screening, being asked the questions, or being asked to go and get tested. So this was the advantage of community based screening, which was not possibly happening when we were going for targeted screening to household contacts and social contacts. And this was the study we had done a few years back, about 5 7 years back. And what the interventions suggested were from the people, like entertainment industry, social media, education, other community interventions. And these were the actually recommendations that came from the patients, their household members, and some key informants from the health system. So this partly is being done in the process of community based screening. So their way, and this way, the stigma and the issues related with stigma is less a challenge when we do community wide screening, is my experience.
That's interesting. Uh, that's really interesting and really important in terms of the uh, the general thought of that stigma would be that it would be challenging to go and do community-wide screening or active case finding. It's really not so. So I'd love to read that paper and understand more. This brings me to Vineet. Now you are at the regional office of WHO. You have member states, big and small, with varied budgets, various constraints of resources also. How do you see community-wide screening in terms of for the countries to take it on in this, especially in the current context now when we see challenges in donor funding? Thank you.
Thanks, Shamim. Yeah, it's an important topic, and just like we were discussing, it is becoming even more important in the recent situation that we are facing. Uh, I would like to structure my intervention into three parts, starting with a bit of history, the context, and what we are asking the countries to do. Now, many of people sitting in the room I see are veterans in TB control, which was the terminology we used to use. And when we started working, there was a Bible for TB control, which was Thoman's book. And, it said that if we could reach 70% of TB patients and achieve 85% cure rate, this was the mantra at that time, then, we would be able to address TB issues. But then why I bring that here is, even at that time, early diagnosis and prompt treatment, these were the words being used. So early diagnosis is something that we know has been the intervention of choice from, like, it's even 20-30 years back, when people started working on TB, they said yes, early diagnosis is something we need to do. Now, with that background, coming to our region, which is 11 countries and just 26% of the global population, we have half the TB burden. Around 5 million new cases of TB appeared in 2023, and it is estimated that half the people died due to TB. And having said that, we have done very well, improved a lot in our treatment coverage. In the region, in 23 itself, we were at 78% of the estimated incidence. That's what we achieved. And this is remarkable. Like a few years back, we were missing 44% of TB patients. Now we are missing 22%. But we also know that reaching these last mile, and that's true for any intervention, is the hardest part. And how do we need to do it? We have commitments from the member states, and we know, all of you here perhaps know about the UN high-level meeting held in 2023, where member states committed to reach at least 90% of the TB patients. So the question remains, how do we plug this gap of 22%? And at the regional office, we've also done a kind of modeling that just reaching the case notification and treatment success targets of UNHLM commitments, we can reduce the incidence by 23% and the deaths by almost 45%. So again, coming back to the point, we need to do more, and we need to do it early for the TB patients. So which makes these interventions necessary. There's like now no question that we do not need to reach out to patients. Now the only question is, how do we do that? Now our experience, and some of the countries I see are here, who have tried from our region some active case finding activities, and sometimes even targeted active case findings, but their yield has not been that high. It varies from almost no patient to just a few patients, and of course in some countries there has been successful. So that's why they come back and ask, is it really necessary, is it really cost efficient? And when they're reporting to the donors, we see global fund colleagues here, and you don't see any yield of TB patients there, then comes the question, is it the priority intervention to be done or not? So what we have been advocating and telling the member states is, and actually we did a review of published literature from countries in the region. This was about 3 years back. And also we took some other countries which had similar socio-demographics, so that we could make it all comprehensive. So there are 3 things which we need to focus on as per the review. We compared what worked in which situations and what did not work. So it's about efficiency, it's about selecting the right population groups, and about addressing the affordability. So three broad areas. When we say efficiency, we need to have that more yield of patients. And for that, we need to engage the communities from the beginning itself. They should be aware that we are going to undertake such activities so that the message goes. And probably what Dr. Sarkar has mentioned, this would also address some of the issues with the reach out and the hesitancy in the community, that whether they should get screened or not, whether that's due to stigma or other things. That's something we can discuss. Then we need to prefer algorithms which are efficient. It's always better to have chest x-ray followed by molecular diagnostics. Professor Guy said we have everything with us. The question is whether we are implementing or using those tools or not. And of course, it's not just about diagnosing the patients, it's also about treating. So many a times what happens is when we are doing such activities, we just refer the patients, and patients by their own may not reach a place where treatment initiation is to take place. So there should be mechanisms that the patients start on treatment there itself. And then we need to keep monitoring our activities, whether they're performing well or not. And of course, selecting the population groups. We have talked about specific groups such as the household contacts, the prisons, uh, people living with HIV, who would be prioritized. Now, I'm not saying that you don't go beyond these things, but for an early confidence in these activities, we need to sort of prioritize some groups and then maybe move to other groups. And of course, if we have examples from within country of such active case finding activities already being conducted, then the experience helps. You can incorporate that experience into if you're planning a new activities. And finally, addressing affordability. Yes, we cannot afford x-rays and molecular tests in all settings. That's like and with these changing funding situations, these are going to become difficult. But that's what, if we really want to improve the yield, that's important. And sometimes a bit of operational research could help. Things like pooling of samples, it's been tried experimentally at some places, but that would perhaps lower the costs of gene expert testing, but probably increase your HR costs. So that's the kind of balance that you would need to take. And finally, I would say that we shouldn't see any intervention in isolation. It's a package. You have to see what goes before and after this. And when you're saying a package, then what we have been discussing since yesterday, the social support package, the counseling, and other interventions, if you can provide nutrition support, all these should complement and come together to if you really want to address that. So this should not be seen as isolation, and the package is what we require to end TB in the region. Thank you.
Thank you. This brings me to Amar. Now, Amar, in your capacity in India, you had been trying to give space to a lot of new innovators. Um, on a lot of technologies are on demonstration also up here in the exhibition. What I really want to understand from you is, for doing any community level screening, what should be the must-haves, if at all? It would be interesting to know that.
Yeah, thanks, Shamim, and good morning, everyone. So I guess one, I think, and it's coming it very clear that like over the decades now, the strategy, mindset, and the commitments also changing, which is on an encouraging sign where we really want to kind of thirst give, and this is an extra effort. Community-wide screening is an extra effort where we see there are statistics available around 38% of the vulnerable population, which yields almost 70% of the cases are coming from that group. So in that quest, I guess, and I'll just second the thoughts which kind of the extreme panelist has put off. Uh, and when we see, and we see also see as a holistic view, it's not. And once we see the must have tools, we just go in more for the yield only. But I think that's a half puzzle. But of course that yield is extremely important. And so, and we are also actually seeing those so for that first part of the yield, what we see, uh, planning, a planning, well planned community wide screening is essential thing. And we have two great examples. One is this 100 days campaign, where the planning was there along with the consultation with the each state. That micro planning went into a stakeholder engagement. And now, to also example, there is a Aswashan campaign which GOI did it during the COVID times. And planning, why it was important in both the cases, like in Aswashan campaign, what they realized that for the tribal community, we have to be there in each district for 100 days. So currently what we have approach is 100 days entire country. Over there the concept was in each village and district we will be for 100 days, because tribal community requires that confidence and trust, then they will allow the active case finding to happen. So I think that's also something which as a innovation we will learn that way. Second, I guess, of course, resources, we always talk about the leveraging the HR and something on the high sensitivity screening tools. And we now are realizing that rather than going for a single disease screening, when we actually do the multi-disease screening, uh, we actually have a better efficiency both in terms of the pulling the resources, HR management, and as well as the for the community. That's a better kind of approach. And I think that also addresses some of the stigma issues, because then it's more of a health checkup for entire community and people are coming, and you are also doing some wholesome kind of activity, which I think yesterday also Dr. Vinod Paul sir also mentioned that there are 5-6 priority diseases. So leprosy definitely can be part of that. And so there are many other diseases can be added similarly. uh, what we also see is some data intelligence, and you talked about as well. So Mizoram is a live example where how other data elements can be added, and that data intelligence either through vulnerability mapping, AI software, and we see this as a added tool. So if you have the data records for last 5 years for any districts for TB, so that exercise, and now we see the some of the excellent data analytics tool. So and this is where we also now see that has to be must, because active case finding without those data engines is not going to give the yield which we are looking for. Uh, and also, I think data capturing tool, which paper-based recording, reporting is gone days now. And for the field, you have to make sure that they have to be user friendly, reliable, and also we can then learn from that data. And that's why you see now many data capturing tools are available. And as a our concentration also how to make that data capturing tool. If we can do that in 1 minute 30 seconds, then data entry becomes so easy, then you can have a larger efficiency. And so that's also has been now we added as a must have. Second part I think I'll put is uh, of course, and I'll just second that it should not end. Community wide screening actually just should not focus on screening TB only, but let's say there are sequences, like, so even if there are no TB, you are doing it in vulnerable community, so then you have to have a vulnerability reduction plan as well. It's also must. So if a person is screened not having TB, you actually screen the vulnerability, provide the preventive treatment, provide the nutrition support, and then that is the where GOI has going now big screen. So that's a vulnerability reduction also. So if that has been the must part of the planning. uh, and third is the leveraging the existing platform, and that's also have become must now. So whether are you in all our community wide screening, are we using the existing platforms like ABDM, are we using existing telemedicine potential, are we using Nikshay Sampak? So that has been the kind of thing, because these are existing available resources, and are we capitalizing? So, and that's why we also see any plan, whether that includes those must. Fourth part, I think it's these are also the opportunity of the learning. We really need to see that how this further can be augmented, and we need to see of any of the community wide screening, can we have some small subset which then no can help to see more on the how we can improve the pre-trace probability. So there are some excellent tool again on the horizon, which still needs some validation, still needs some mentoring, still needs some piloting. So let's say cuff AI, or maybe tongue swab tests. So they can be added as a thing. We really can't have a now or the opportunity or the time or the resources to do an exclusive study. We need to find some pragmatic approach where in existing setting, without burdening the staff, how can we do some excellent OR, operation research, or implementation research, which can kind of real. And last, I think we'll add is the openness to the learnings. And I think I'll again compliment GOI CTD here. They did the commission research on yield of the active case finding. So now that's published data available, and over there are like 5 to 6 kind of learnings available, that like staff morale, staff incentive, the also the how to do the micro planning, and also what is that ideal geography wise yield look like. So I think openness to research is something which is a must, and I would just end with that. Thanks.
We have still 5 minutes, and this is an open question to the panelists. The thing is, what clearly we need is it really seems resource intense, right? And what we see is, when we started the discussion, I said like, no, we are in a situation where we have fixed budgets to overall health budget. In terms of, then you come down to TB budget, and the infrastructure which we have for TB, be it the tools which we have, these are all more of these are all more of uh, which were designed for passive case finding, not really for active case finding. Massive infrastructures. So, do you see that if we really want to do community-wide screening, how should we be going now in this changing scenario? Can we do some adjustments?
You want me to say? So I think the several people have said, that the current situation we're in is a huge challenge. But the reason it's a challenge for TB is because there's still an enormous amount of TB around. It's not a challenge for countries which have already eliminated TB. We don't have to spend money on TB, and it makes the case that well, ideally we should have been doing this 10 years ago. Then we would have been in a much better position, but we didn't have the tools that we have now. We now need, I think, even more urgently to reduce the burden of tuberculosis quickly. So I think there's an economic incentive and a necessity to do it. I think we can reinvest some of this will come from disinvesting in some activities, and you were sort of implying this in your question. Disinvesting in some activities which were more suited to previous understanding about TB and previous technology that we had available to previous treatments. So, for example, virtually nobody should now be being hospitalized for management of TB unless they're really seriously ill with hemoptysis or respiratory failure or something like that. The vast majority should not be. And so we should not be spending money on that. The role of reference laboratories is hugely changed. We don't really need culture for most patients with TB. We need surveillance. We need surveillance for drug resistance and for understanding the molecular epidemiology of TB, but the actual the role of reference laboratories in training and quality control on sputum smear microscopy, for example, is not needed now. So we need to think about some of the things that we still invest in, even the need for a separate MDR, TB, PMDT program is, I think, something that needs to be questioned. So we need to start thinking about how we can reinvest. There is no doubt, though, that we do need additional resources up front to facilitate community-wide mass screening for TB, and that will require financial models that allow us to invest at the beginning and recoup those funds later on out of the benefits of the investment, and that will require things like development bank loans and financing models such as that. I just, if I mean one thing, I just want to, I think, Professor Sonali, your point about social capital and about the disbenefits of targeted screening, or the disadvantages of targeted screening, is a very important one. And my argument would be that actually targeted screening is another thing that is expensive and not necessarily generating any epidemiological benefit. Screening a small proportion of the population where you might have a high yield, but you actually find a very small proportion in total of the number of infectious cases, has really no impact on the epidemiology of the disease. And I would argue that we should not be investing resources in targeted screening, actually, that we should be investing those resources in geographically targeted screening, but not in targeting individuals because of their risk factors. We can start with the highest burden geographies, but we need to screen everybody in those highest burden geographies. And the other last point I would make is that it's not a once-off thing. We're not going to, the biology of TB is such that it's a very slow disease. And some people who will develop TB in the next 6 to 12 months after you screen them, you won't get when you first screen them. So you need to do this for a few years until you drive down the prevalence and the incidence sufficiently. I'll stop there.
Last point.
Yeah. So just to because your point, an alternative idea which we can try is consumer-led periodic health checkups. It is, I think, the demand where we can really link up. Right now, let's say government provides the incentive for every citizen. If we do the periodic health checkup yearly, you get the income tax benefit. Similarly, I think that is where it will come. Someone needs to bear the cost. But I think if we can incentivize, and that will come to a behavior change rather than proactively government's responsibility or the overall stakeholder to actively go and where the community is seeing as a passive. If we can, and that's again a thing where community consumer led health checkups, and which includes TB. So I think that is where in this era we can kind of think, but of course that's a learning which we need to create.
So just to add to what Professor Guy was telling, I'll just slightly deviate in the beginning and come to the resources. What has happened till date is we always try to have that one size fits all formula. If one study says that the prevalence was higher in household contacts in Pune, that becomes the norm for the rest of the country. But TB epidemiology is very varied across the regions in the country. I mean, what you find is the risk groups or pattern of TB in Mumbai slums is not the same as in Pondicherry. The risk factors distribution is also so varied. In Pondicherry, we see about 60% of our TB patients have a history of alcohol use, whereas in rest of the country, it's not more than 30%. So the risk behavior also is different, and TB epidemiology is also different. So when targeted screening is done for household contacts, it gives hardly any yield, because for a long time when we were seeing household contacts and we were not getting even incidence of 0.5 TB among the household contacts cohort, everybody was telling us that you're missing out cases, you're not trying to you're not able to identify all the cases. But it's not so, because in Pondicherry the distribution of TB cases among alcoholics, transmission is more among alcoholics, and therefore if you go ahead with targeted screening of household contacts, you will not get the yield. So to start with community based screening, yes, definitely our experience in it's reduces the stigma, and the resources that was going into the targeted screening can be utilized more. But to in the community-wide screening, we are missing out some groups. I mean, this especially our experience of people who are having alcohol use disorders, and they are probably having a higher burden of TB, and they also, the behavior is such that they don't have a good health seeking behavior. They come to the health system very late, probably have a higher burden of disease and transmitting disease. So these are the groups which are also less accessible, and I think the program managers should devise ways and approaches appropriate to their own setting based on the epidemiology of TB in their area, and not go by a national formula to be followed everywhere. And if we have a knowledge of the epidemiology in that region, in that area, in that locality, town or city, we can think how we start, where do we start the community wide screening, of course, but some risk groups, to see that they're not missed out, because people with alcohol use disorders are often missed out in even in community wide screening. And so that also would help, I think, make it more efficient and affordable, and the groups that Dr. Vineet was addressing.
Right.
So just 2 cents. Thank you.
Thank you. Thank you so much for your overtime. I'm sure we would have gone on and on this. I'm sorry, there are no panel questions. Like, this is what it was for the roundtables, and we overtime. Oh, we can discuss outside once we are out. Thank you so much. Thank you so much for your participation.
Thank you so much for having such an engaging panel discussion. I'd like to request the moderator to hand over a token of appreciation to all the panelists.
Oh, that's all.